I'm going to talk to you about seizures today. And the theme that's been going on this morning is like giving you the right vocabulary and the right tools to talk to your physicians about that. I just wanted to start with what is a seizure. So your brain's made up of a number of different neurons, and those take turns communicating to be able to send a signal to your body to tell you to move your hand, move your leg, things like that. But if they all try to talk at once, then that gets disrupted. And the way they talk is through electricity. So a seizure is an abnormal electrical discharge that's happening that has some kind of manifestation, although not always. Sometimes it can be just that we see it on the EEG when we look at the brain waves. And then what is epilepsy? I like to talk about this too because oftentimes when I tell a parent that I'm diagnosing their child with epilepsy, there's this big wave of disappointment, and there's a lot of stigma that historically has been attributed to that word. But really, epilepsy is just a fancy term for being at risk of having more than one seizure in your lifetime. So this is the technical definition of two unprovoked, meaning the seizures weren't caused by something that we could define. It wasn't an infection of the brain or something like that. Or you've had one seizure, and then we do an EEG or something in your history tells us that you're at risk of having more seizures in the future. Seizures themselves are actually really common. So all of us in the room have a 10% chance of having a seizure for any reason in our lifetime. And then epilepsy in the general population is about 1 to 3% of people. So in a college lecture hall, there's probably 1 or 2 people in that room who have been diagnosed with epilepsy. And then children, it's even more common. So there are epilepsies that some children outgrow, we see it a little less in adults. And then there's things like febrile seizures that you may have heard of that are a common occurrence in small children that doesn't portend that they'll grow up to develop epilepsy. And so then, we already mentioned this earlier, but seizures are a unique feature of juvenile onset Huntington's disease. And so it can be a presenting symptom. It's not one of the more common ones, but sometimes that is the first thing that a parent may take note of. And then I think earlier we said 30 to 40%, but a lot of our studies are what we call cross-sectional studies. They just look at a snapshot in time and they don't look at the whole course of someone with JoHD. Quite often we're guilty of this as clinicians. We find a case study or a patient and we publish it, and we don't go on to publish what happens the rest of their life. So it could be up to 50% of children that eventually develop epilepsy if they have Huntington's disease. And then it's really important because Elder Coyle had done some nice papers looking at this in the English population, but it's one of the symptoms that leads to hospitalizations more often and also can cause a lot of distress for families. And so seizures are more common with a higher CAG repeat number, and they're also more common the younger symptoms start. And so have actually been included in the diagnostic criteria for childhood onset epilepsy, or childhood onset JoHD. Again, just to give you some more vocabulary, so when we talk about seizures, there are 2 big bins that we put them into. It's called generalized epilepsy, meaning that it starts in the whole brain all at once. And when someone has this type of epilepsy, they are not conscious, so they lose their ability to interact with their environment. And then there are focal seizures, which means that seizure starts in one part of the brain, and sometimes it just stays in that part. And so all you might see is the hand shaking, and it may or may not affect whether or not they're aware. But your child may be aware that their hand is shaking and be able to tell you that, and it may seem odd that they're still able to interact with you, but that can be a seizure. And it could affect their cognition too, though, so it can go either way. And then focal seizures can also spread to eventually affect the entire brain, in which case you would lose consciousness. And so in JoHD, what's been described are really that kids can have any type of seizure. There's a lot of different types of seizures, but the most common are these 3. Generalized tonic-clonic, you may hear your doctors use that term. The old colloquial term for this was grand mal. So this tonic means stiffening. So you can have just a tonic seizure, and then clonic are rapid movements, and then you can have a combination of that. And when you have the combination, that's that generalized shaking that you think of when you think of a big seizure. Myoclonic are brief little quick jerks, and these can be either epileptic related to seizures, but you can have myoclonic jerks that are a movement disorder and are not abnormal discharges in the brain. And so that, especially in JoHD, can be difficult to tease out. And then absence. So this is staring spells. Usually it's brief staring spells. If someone's staring for minutes on end, it's probably not a seizure. And usually a kid, like if they're coloring, they'll stare for a few seconds and then go right back to what they were doing. Unless, of course, they were doing something like riding a bike. And then it's not uncommon to see things that we call automatisms, like little lip movements or finger fumbling during that staring episode if it's an absence seizure. And again, just like we talked about with mood and behavior symptoms, one symptom doesn't make a diagnosis, even in an at-risk person. And so these same types of seizures that we can see are also common in just general childhood epilepsy syndromes. So childhood absence epilepsy is one of the most common childhood syndromes, usually 4 to 10 years of age for onset, and this is one that typically developing children have a good chance of outgrowing. But we see a lot, and so if you can have true and unrelated, you could have two things. And then juvenile myoclonic epilepsy, so having those short little jerks, and sometimes they do have the bigger seizures, the generalized tonic-clonic syndrome as well, is one of the more prevalent seizure types in teenagers too. So again, trying to tease out, is this actually related to being at risk for HD, or do you just have a very common epilepsy syndrome aside from that? And what do you do if you think your child's having seizures? I think this is good for everyone to know because not everyone makes it to a child neurologist or an epileptologist. Videos can be really helpful, especially if we're trying to tease out, is this a movement disorder, is it behavioral? Sometimes behaviors can look like seizures, even big, crashing, convulsive movements. And so a video is worth 1,000 words, but it's a scary event. If you can't take a video, that's okay. But now that everyone has iPhones, it's gotten easier and easier to get videos. Try to get your child's attention. You know, ADHD is common. And if they're just not paying attention, really don't just call their name, rub their shoulder, tickle their ear, really try to engage with them to see if you can get their attention. Contact your doctor, let them know that's happening, and don't be afraid to ask, could I see a child neurologist or could I see an epileptologist?
Yeah, I was gonna ask that. I love my neurologists. They're awesome. With that, I mean, you've never seen an epilepsy doctor ever, so at what point?
So everyone has a different comfort level, and I would hope that no one's doctor would be offended if you ask them, what's your comfort level with managing this? If you're seeing a child neurologist, because seizures are so common in children, many of them feel very comfortable working through the first few medicines. And if you're in a predominantly an adult neurologist practice, they may feel a little less comfortable with that. And you may not need to see another doctor. They may have someone that they work with that they can phone over and save you the trip. But I think it's always good to just have that conversation.
I think for Chloe, for example, I mean, we could just not get her seizures under control. She had chronic seizures, and we would try different medicines. Would an epilepsy doctor versus a neurologist doctor, the epilepsy doctor know more better ways?
So they're more likely to consider a wider variety of medications, I would say. Not necessarily better or worse. Yeah. The more and more medicines you try, the less and less likely you're going to be seizure-free. You might still make an improvement in the seizures. But yeah, I'll get to a cycle. We have a lot more medicines than we used to, but I will say if you're not an epileptologist, most people aren't comfortable with some of those other medicines. I'll fly through these, but what to expect. The only actual workup that's recommended in guidelines is to get an EEG to look at brain waves. Your child may have an MRI or other lab tests, things like that. That's on a case-by-case basis based on what is in the history. And then there's a lot of different types of EEGs. So you'll hear us talk about these terms. Routine is where you just come into the lab, we put all the little electrodes on with the little sticky goop, record for about 20 to 30 minutes, and then take it off. So the whole process is about an hour. And that gives us a snapshot, and sometimes we see abnormalities that give us a clue as to whether or not they're having seizures or epilepsy. But if we're really trying to differentiate movements from seizures, then things that are longer can be really helpful, and catching sleep can be really helpful too. And so you can just go to the lab and get a longer study, which we refer to as extended, like 1 to 4 hours. But there's also at-home EEGs, which we refer to as ambulatory. Or if you go to the hospital, either they can put you on an EEG with a video just in any room as part of the workup, and we can record for, sometimes what we do is we make planned admission and you come to a specific room that's set up with videos. And we can usually watch for a week, sometimes more. The week's usually the cutoff because the blue starts to get a little irritating for the scalp at that point. And that's about the time when parents and kids are really kind of,
How long? So Chloe's her whole time. She got one at 4 when we were in the hospital, and then she got one when she started having. And then Ari, she has one. We had an overnight stay. How many times do you suggest they get those done?
Yeah, it really just depends. It's a balance of like how easy is it to come in and have the study done, and how much information are we going to get from it. And so especially if your child's predominantly having what we call clinical seizures, if there's something happening that we can see and you're reliably able to tell, we don't really need to keep getting EEGs.
Okay.
But there are,
it is what it is, and like
and then, so then at that point it's like adjusting medications, talking to you about how much it's impacting life, things like that. But there are instances where they may have behavioral problems or cognition may be impacted, and what we're seeing are just seizures that we can see on the EEG and not at home, or it's just really hard for you to tell what's a movement and what's a seizure, and those are instances where we may be more likely to get an EEG more often. Things that make it more likely that a seizure can break through are sleep deprivation. So sometimes the first time we notice a seizure is like after New Year's Eve when people have been up late, or slumber party, illness, and that this really goes for anyone. When we get into teenagers, we start thinking about drugs and alcohol, but also when we're thinking about different medications that someone may be on. Some medications lower what we call your seizure threshold, the likelihood that a seizure will come through. And so if someone's on certain medications and a seizure happens, we might ask, oh, do we maybe need to just pull back from something? And then if you're already prescribed anti-seizure meds and you miss them, that puts you at risk for having a seizure. And so this is that graph I alluded to, but just showing you how many more anti-seizure medications we have now. And so if someone trained even 10, 20 years ago, there are a ton of medications now that we can use. And so some of these people are probably not as comfortable with, and especially not as comfortable with in children. So like cenobamate, for example, is one that is not actually approved in children yet, but is being used more and more often, especially in other instances when we're thinking about surgical candidates is commonly. And so that's a medication where your general neurologist is probably may not even be familiar with it and won't feel comfortable with. But a lot of these have now been used for very difficult to treat things like Dravet or LGS. And so we may have good overlaps in HD, but we just don't know yet. And I don't think anyone's using it.
I just thought of this, and I don't even know this thing, because epilepsy on its own is its own disease, correct? And then, I mean, I know it's a side effect with JHD.
Yeah.
Is there trials for epilepsy in general that they're willing to do on kids to?
Yeah, so that's tricky because the trials all have different criteria for being enrolled. One of the more common ones is that like you have to be on a stable regimen for a certain number of months for any trial, because they don't want the confounding that you're changing something else. So if there's a lot of changes going on, that may be difficult. Age for anything, but I think in just a general epilepsy trial, you're more likely to find younger age groups. But then there may be limitations on what other comorbidities or diagnoses a child has to be in this study.
Since they have one.
Yeah, but if you're getting into medications that are either difficult for insurance to cover or difficult to access or just newer medications, like asking if there's a trial nearby is a great option, because that also has mechanisms for covering costs and things like that. And so I'm not going to go into the nitty gritty of medications. I already derailed Jordan's talk about Epidiolex, but what's been described historically is that valproic acid is probably the most used and most effective, but it's also one of our older drugs with a lot of side effects and interacts with a lot of things. And so it needs blood monitoring, but it has good effects for other things like moods, or like you mentioned in the height panel, they can make you gain weight, things like that. And so we may pick that for those reasons. Other medications that have classically been described as being used more often are phenytoin and carbamazepine, which as a child neurologist we don't really use anymore because of their side effects and have better kind of sister medications to them. And so that's another thing where if you're seeing adult neurologists, they may still use those, and not be as familiar with things like carbamazepine, Tegretol, and then like sister medications are trilactol or Aptium, which are more common in children. And I'm happy when we have a panel to take more questions about medications. If someone has a seizure, make sure they're safe. Do not put anything in their mouth that's an old wives' tale. Your tongue will heal very quickly if you do bite it. And then time the event. Seizures that last more than 5 minutes are likely to need a medication to help them. So you're getting towards that time point, that's definitely a time to call 911, or if you see that they're having any trouble breathing. And then if the child's prescribed a rescue medication, administer that if you have it. It's okay if you don't have a rescue. It's okay if that wasn't prescribed to you. EMS comes with that medication when they respond. And then a common question is,
What's a rescue medicine?
oh yeah, sorry, another vocab. Yes, there's 2 different types of medicines. So there's anti-seizure medications that we use for maintenance that are usually twice-a-day medications. There's some once-a-day medications. And that's a medicine that you're taking every day to reduce the risk that you have a seizure. But then if you have a longer seizure, there's separate medications that we use to help stop it in that moment. And those medications are all in that benzodiazepine class that Jordan was talking about. And so that's going to be things like rectal diastat or Nasolam, which is a nasal spray, or sometimes we use like a Klonopin wafer, which is a dissolving tablet. You can also give liquid, which can be useful if someone has like a G-tube or something, but usually rectal or nasal is easier because you're not trying to put something in the mouth while someone's having a seizure. And then kids can do all of the same things other kids can do if they have seizures. Obviously, you should wear a helmet when you ride a bike, like all the kids really should be doing, because the seizure itself, for the most part, especially short seizures, do not hurt the brain. It's what happens if you lose consciousness when you have the seizure. So if you're riding your bike and you fall off, if someone's into rock climbing, we say don't boulder, do belay, have the safety system in place. And then the big one is swimming. No ocean, open water swimming. Be in a pool with an adult with you in the pool that knows that you could have a seizure. And then showers, not baths, unless there's someone with you watching you in the bathtub, which a lot of kids aren't going to want.